program, why is it important? Because all of us, we know that one of the most important step in today's date is not only that we should be saving
Chitra madam, please start the program, ma'am.
Okay, fine. Okay. A very good evening. And at the outset, let me thank Fox for having taken this initiative to spread this RAC to all its society, to all the 256 societies that we have. And the same thing is being told in all the societies, so it's uniform. So it's very, very useful. In fact, what I'm going to talk to you all today is about MTP Amendment Act. Now, can I just share my screen 1 minute? Okay, so this is the first module. It's about medical termination of pregnancy, the Amendment Act in 2021. Actually, for a long time, why should we have this MTP Act, which is amended? Initially, from 1971, we've been all familiar with the MTP Act. But what was the need to have this new act? That's simply because we identified many people becoming pregnant after the 20 weeks and 24 weeks and requesting for a termination of pregnancy, in which case they had to go to the court, and there was very difficulty in procuring these abortions, and many of them sought to illegal abortions, as a result of which there was a lot of effort which is taken on. And in 2020, the Lok Sabha passed this act, and finally in March 21, this act was it came as a law. So from then on, we've been having this MTP Act. So it's very important that we know what are the changes in this MTP Act 2021 and how does it differ from the previous act. So this is what I'm going to talk to you all over the next few minutes. Now, so what are the new rules and what are the changes in the new rules? What are the very important salient features is what I would be touching upon. Now, unsafe abortions, as you know, it is a very important cause of maternal mortality. And now we are striving towards bringing down the maternal mortality to as low as possible. And one of the most important causes of maternal mortality, in fact, unsafe abortions ranks third amongst contributing towards maternal mortality. And when we talk about these goals, it's important that we try to bring down this maternal mortality because of unsafe abortions. And like I said, it's a third important cause of MMR. And most of the abortions earlier on, they were done in unsafe conditions, and that increased the rate of maternal mortality because of sepsis, etc. And most of the abortions occur in individuals which are less than 24 years. So now the WHO has said it's not important who does the abortions, it's also important how we do the abortions, where you do the abortions. So abortions, it's important for us to follow this RAC, which is respectable abortion care. So not only should we look after the patient carefully and treat them with dignity, it is also important to know how to do the abortions, where to do the abortions. Now, abortions are safe only if both the criteria are met. In sense, when you do it in the appropriate methods, when we do it by trained person, because we know that many of these abortions are done by untrained eyes. Now, why this untrained eyes come to picture is, supposing you have a person coming to us after 20 weeks of pregnancy. Earlier on, we used to say this is not permissible by law, so you go away. And as a result, many people went to local dyes, and they ultimately ended up having an unsafe abortion or a septic abortion. So when you do it by untrained persons or by methods which are not really advised, then it becomes very unsafe. If both the criteria are not met, if it's not done by a trained person and it's not done by appropriate method, that's the most it ranks highest. It's unsafe. Whereas if it is one criteria is that you do it by a trained person, however, you don't follow the appropriate methods, that is less safe. However, it is most safe. Abortions are more safe if you do it by appropriate methods and by trained persons. So the next, in the course of this webinar, we would be seeing what are the various methods in which you do the abortions and how and when we do. So like I said, in 2021 March, this MTP Act was amended and came as an act. So let us see the salient features and compare it with the previous act. Now, the most important changes is to how long can we do and who can do it. So now all of us know that earlier on the pregnancy, we could only do a medical termination of pregnancy till the 20 weeks of pregnancy, but now it has been moved to 24th week of pregnancy. That is one of the most important factor in this amendment. So let us take up one point by one point. So initially, we used to have, after 12 weeks of pregnancy, only one person, one RMP was registered medical practitioner, was sufficient to give an opinion. And from the 12th week till the 20th week of pregnancy, because there in the previous act, MTP could be done only till the 20th week of pregnancy. Once it crosses the first trimester, in the second trimester, from the 12th week till the 20th week of pregnancy, you had to have 2 medical practitioners giving the opinion that you could do an abortion. Now that has changed. So what has happened there? It's enough if you have one registered medical practitioner to give an appointment till the 20th week of pregnancy. So instead of 2, now it is sufficient if one person gives an opinion. And from the 20th through the 24th week of pregnancy, only under such circumstances you require 2 RMPs for termination of pregnancy. That is a very important thing. So now, increase in number of faculties, especially in PHC, that is very, very useful, where you don't have any people, and then so you have to run around for another person. So if you have only one person, it's much more easier and simpler for the patient. So the entire act is based on making it very safe, easy, and easily approachable for these patients. So that is why all these routes have come into picture. So if you do go to a PHC, it's enough. There's one particular doctor there, and that particular doctor can, it's enough if that particular doctor signs. And then again, this is the most important thing. MTP is permissible only up to the 20 week of pregnancy, but now the gestation age until which you can do MTP is enhanced from 20 weeks to 24 weeks, especially in vulnerable categories. We will shortly see who are the vulnerable categories. And after the 20th week of pregnancy, there is really no limit. You could, if you come across a person who has a birth defect, then you could continue to do the abortion under certain precautions, certain legal issues that we will come to later. So, so now I'm sure all of us would have come across situations where a person has an ultrasound and then she detects some anomalies, and then she doesn't know what to do. Even very recently, we had a person, she had a skeletal abnormality. She did not know what to do. By the time she came to us, it was almost 25 weeks when she came to us asking for an abortion. So we had to apply to the board. We could not do the abortion. We had to apply to the board. So it took her almost 5 to 6 weeks to find out where to go for the abortion. So it takes a long time. So when she comes, we cannot say, okay, you go ahead and continue the pregnancy, but now you have a provision where you could provide them the necessary care, because it's still, she does, you know, there's a baby having a lethal abnormality. It is but her right to have the termination. So it's important that you guide the patient appropriately. So under all these vulnerable categories, it is possible for us to have this abortion even after the 24th week of pregnancy. So like I said, in previous act, you could only do the abortion to the 20 weeks of pregnancy, but now there is no upper limit. You could do whenever, especially whenever there is a fetal anomaly. Even if it crosses the 24th week of pregnancy, it is still possible for us to apply to this medical board and do the abortion. Because that is very important, because many people, everybody, even though they don't go for a routine checkup, all of them will have an ultrasound. And by the time they have the ultrasound, then they will go for a second opinion for the ultrasound. It becomes 20-24 weeks. And then when they come, it's important that you guide them correctly. Now, so that's about the first point. So abortion can be extended until the 24th week of pregnancy. And even if it's a fetal anomaly, it could go beyond the 24th week of pregnancy also. That is point number one. Now come to the next point. Now, initially, it was only MTP was only applied for contraceptive failure for the only for married women or a husband. Now, but now, condition of failure of contraception could be extended both to the mother or her partner. It doesn't say husband, just says partner. Partner could be anybody. So even if they're living together, then also she's I mean, it's acceptable, and you could do it on contraceptive failure. So woman or her partner, it doesn't say her husband. Okay, that is important. Okay, because now we know there's a lot of changes in legal age of marriage. So it's important that you extend the abortion care to all these individuals who are living together. Now, next is how do you maintain confidentiality? So initially, they said that information should not be disclosed. Now, we're not supposed to disclose to anybody who is having the abortion. So in the previous act, you should not, the information should not be disclosed except under authority of law. Now here the same thing. So name and other particulars of a woman who has to be terminated should not be revealed except authorized by law for the time being in force. So the same thing, you should not tell anybody, disclose the particulars of a person. So it's very, very important that you maintain the confidentiality. So all these registers should not be kept open in the labor ward. They have to be kept under lock and key, and we're not supposed to, they should be sealed, and we should not supposed to tell who's having the abortion under what circumstances. That's very, very important. So it's important that you maintain the privacy and confidence, because nobody will want to know that she's having an abortion. So it's very important that you maintain this privacy and confidentiality of all the abortion seekers. Like I said, now it's the contraceptive failure has been extended not only to women but also to her partner. So next we shall see for all the vulnerable category. It's come and we will discuss about who all can do the abortions. So let's move on to the vulnerable category, because in vulnerable category you can extend the abortion from 20 to the 24th week of pregnancy. Okay, so these are the 7 categories under who are called the vulnerable category. Special category under for women for whom we offer abortion between the 20th and the 24th week of pregnancy. One is survivors of all rape, because sometimes they could come to us very late in pregnancy. They realize that they're pregnant only very late. So for all survivors of rape, even if they come between the 20th and 24th week of pregnancy, we can procure abortions. We can counsel them and then go ahead with the abortion. The second category is women with pregnancy under humanitarian settings or like disaster, especially when we had this COVID condition. People were not coming, and by the time they came to us, it is very late. So even if they come to us after the 20th week of pregnancy, we're still certified to where we can still go ahead and go with the abortion, or in all emergency situations. So whenever a person there are some circumstances under which she's not able to seek medical help when there's some disaster which is happening. So even if she comes late, she becomes a special category under whom it's possible for us to go ahead with the abortion. The third one is change of marital status during the ongoing pregnancy. Suddenly she finds that she's lost her husband, she does not want to continue the pregnancy, or she's a divorcee. All this is becoming very common, in which case she may not want to continue the pregnancy. So in such conditions, it is but right that we give her the abortion help. The fourth one is women with all physical disabilities. Then again, it is possible that we offer abortions to all of them. If they come to us, we can give them the abortions. And mentally retarded women, if they come to us late, then also they become a special category. And all minors less than 18 years of age, they also come under this category. And any fetal and any baby which is having some anomaly which is incompatible with life, they're the last category. So under all these special categories, we can extend abortions beyond the 20th week of pregnancy till the 24th week of pregnancy. But remember that it's not only till the 24th week of pregnancy. Under special circumstances, we could also go beyond the 24th week of pregnancy, especially if you've identified some major anomalies. So who all can do this abortion? So medical practitioner, so there are certain criteria. Like I said earlier itself, we saw that till the 12th week of pregnancy, it's enough if you have only one. But in this new law, till the 20th week of pregnancy, it is enough if you just have one certified RMP. So the old act, who all was capable of doing the abortion? One is a person who was assisted in 25 cases of MTP and who's at least done 5 MTPs individually. That particular person is certified. And secondly, that particular person has completed 6 months of house surgency in ONG department. That person is also capable of doing the abortion. And all PGs, if they've completed their course, whether it's a degree, MD, or diploma, they're all certified. If they have the PG course, if they've done the PG course, they're all certified. They could go and do the abortion. And if they've had at least 1 year of experience in the field of obstetrics and gynecology. So all this, so at least 25 abortions, or they could have at least worked 6 months, minimum 6 months in the department of ONG, or all PGs are capable, or they become certified RMPs. And again, a person who's worked for 1 year in the department of ONG. All these people are capable of doing an abortion. So again and again, remember, till the 20th week of pregnancy, it is enough if one opinion is obtained from one RMP. From the 20th to 24th weeks, you require 2 RMPs. And beyond that, it is only the medical board who has to certify. Now, in this new act, there's a new category of provider has been added, especially for termination till the 9th week of pregnancy. Because people, because now we have your manual suction evacuation, MMA. So for such cases, if the pregnancy is less than 9 weeks, so it's enough if a person, you call a certified person, if she's had worked in the department of ONG for just a period of 3 months, or they've had 10 cases of MTP by MMA under supervision, then that particular person is fit enough to do the abortion. So that's a new category which has been added. So let's see, till 9th week of pregnancy, you have 5 different categories of people who could do the abortion. All PGs, all people who worked in the department for 1 year, all PGs who worked in the department for 6 months, and again, all people who've had 25 MTPs, which they've seen, which have assisted and done at least 5 MTPs under supervision. And in addition, if they've had 10 cases of MMA, if they've seen 10 MTPs by MMA, all of them are capable of doing abortion till the 9th week of pregnancy. However, till the 12th week of pregnancy, so the first category gets excluded. That is the person who's done only 10 cases of MMA. That person is not certified to do the abortion. All the others will fit inside. So that means basic minimum is they should have had 25 cases of MTP they should have done. And all the other 6 months, 1 year PGs, all the other people also are certified. Now, when it comes to beyond 12 to 20 weeks, you definitely require more expertise. So in such cases, you should at least have worked in the department for at least minimum of 6 months. So you have only 3 categories of individuals. They which should have worked in the department for a period of at least 6 months, or they should have worked in the department for a period of at least 1 year, and all those who finished the PGs. Then they are all the 3 categories who are certified to doing the abortion. Now, when it comes to 20 to 24 weeks, means it's a little longer time, in which case you have only 3 type of people who could do 6 months, minimum 6 months, or 1 year, or all PGs. Now, when it comes to beyond 24 weeks, then only PGs are supposed to do, or if they've had at least 1 year of training in the department of ONG. Now, if it's beyond 24 weeks, then you require a medical board. Now, we shall see who the medical board consists of. So, the medical board consists of a gynecologist, a pediatrician, and preferably a radiologist. So, every state is supposed to have a medical board. And so, after the 24th week of pregnancy, we want a pregnancy to be terminated. You should write to this medical board and say which category you want this abortion to be done. And they would go through the case and then decide whether this abortion can be done or should not be done. So these, this tumor board, once you apply, they would tell us, and that the time limit is they should be able to tell us within 3 days. and you should finish the abortion within 5 days of filing the case. So this function of the medical board is to examine the woman and her records, and they would provide the opinion in the Form D, which is there in our MTP forms, and they will either decide whether to continue the pregnancy or whether she has to undergo termination of the pregnancy, depending on various factors, which includes the gynecologist, the pediatrician, and the sonologist. And they should say yes or no to this within 3 days, and from the time the request is filed, within 5 days. As soon as it comes to us, we should start doing the abortion. So within 5 days, she should have the pregnancy which is terminated. And Foxy has a very important role in seeing that every state has a has a medical board. Okay. So by these simple rules and regulations and changes in the Amendment Act, the government of India has trying to see that abortion is made much more safer to all these individuals, and it is the patients, the woman's rights are respected, whether to continue the pregnancy or terminate the pregnancy, so she can take her time, because anomalies are only detected after the 20th or 22 weeks. So it's simplified, and the number of people, because we do not have that many people, especially in the periphery, so the people who could do the abortion are also limited. So they've given very strict, very simple criteria, very clear criteria about who could do the abortion, what should sign. So the law is much more simple. So to conclude, the law has extended the abortion till the 24th week of pregnancy. After the 24th week, from 20 to 24 weeks of pregnancy, there are 7 vulnerable groups for whom we could do the abortion. Beyond the 24th week of pregnancy, if it's really warranted, then you could apply to the medical board. And if the medical board says yes, within 5 days, you could do the abortion. Now, who all could do the abortionists? There are 5 different categories. The lowest, all the 5 could do till the 9th week of pregnancy. From the 9th to the 12th, 4 category could do. From the 12th to the 20th, 3 category. From 20th to 24th, there are only 2 category. And after the 24th week of pregnancy, only the medical board who should decide. And in such cases, only the gynecologist it should go to a referral center to have the abortion. So the changes are very important, so all of us should know, because it's very common. People still come to us, and even if they come late, it's important to know where to guide them and who all could do the abortion. So I think that finishes it. Any doubts? I'll be willing to take the doubts, and thanks for giving me this opportunity.
Dr. Chitra, can I ask one doubt query myself?
Yeah.
This regarding this board, right? But initially, should it be only at state level, or can it be at an institute level?
It can be at an institute level also, ma'am.
Because these guidelines are not clear. Actually, in Japan,
yeah, it's not very clear, but in Coimbatore, in our city, we have it from government hospitals, so they have formed the board there. But I think when because it's very difficult with the state, there's only one person. You could have an institution also.
Yeah, that's what we have done. But again, the query is there, so we are stuck. So that's why we are not. We were doing 1 or 2, then again we were asked to stop.
For us, it's actually easy, because from Coimbatore we send it to the JD, and then from the JD they have the board there, which is consisting of the HOD from Coimbatore, one radiologist. So they give us within a day or 2, they give us the opinion, and then we go ahead. So I think that should be, when it's possible in Coimbatore, it should be possible in Pondicherry also.
No,
I think in institutions,
but there was a doubt.
So because we have already, the tumor board was, the medical board was already there. So it's easy for us.
Yes. And one more thing, I've always done with humanitarian, it's a very broad term. What do we exactly mean by humanitarian ground? Because most of the women who married women who come are like third gravida, just like that, they've not used contraception and they're asking for MTPs.
But actually under this RAC, so initially we were saying, okay, I will not do now. We were also doing the same thing, third pregnancy, why did not have the contraception, and then we used to send them away. But after having listened to them, if you don't do it, they will get the abortion done somewhere else. And it's not going to be safe at all.
But aren't we erring on that? Why are we not supporting contraception rather than,
it's not that we're not supporting contraception, it's just that they don't want to accept the contraception.
No,
how many times you tell them, you told them again and again.
I agree, Dr. Chitra, but many of the time it's not the patient's fault alone. It's we who are responsible, not counseling them. And I strictly feel all of us should counsel them for contraception, and many of them will accept, which is not being done. This is sincerely which I feel is a big problem in our country.
Yes, ma'am, I agree that in some places they may not be able to tell, but from my own personal experience, every time during discharge, we tell the patient you must come for contraception. When she comes after 2 weeks for follow-up, we'll tell them you have to do. Invariably, they come back after 6 or 7 months. We would have documented very clearly and told them also, you have to have all these things. We tell them all the contraceptive methods which are available, but then they come back and say, we did not have time. Then I ask them, you don't have time to come, but now once you become pregnant, where do you get the time? So they simply don't want to accept because it's been handed over in generation, but all these methods are associated with a lot of problems. Many of them still don't want to accept IUCD, which is one of the best methods of contraception, what I feel. And then they wait for them to get the periods. By then, they would have already got pregnant. So we should promote, and this post-placental insertion, PPIUCD, strictly speaking, we should really get the consent. When we ask for the consent, people are not willing at all, especially in private centers. You give them a consent and then go by law. They're not willing at all. I'm very sorry to say they don't accept at all. They don't initially on the table they will say yes, but after that they say no, we don't want a contraceptive. That has been our own experience.
Anyway, I feel we all should have such meetings for patients more towards contraception rather than just promoting MTPs. Yeah, that's my take on this.
Yeah.
Yeah, ma'am. Hello.
Should we proceed with the second module?
Just, madam, I have one query. If you can find it, please.
Yes, Dr. Dinesh.
Yeah, one thing is that we used to read that after the fetus product is 500 grams, then we should take it to a death certificate. So is it still valid after this modification of the MTP Act?
Dr. Dinesh, the question is not clear.
If we are doing and the product of the fetus expelled is more than 500 grams, should we issue DC or not?
Products of consumption more than 500 grams should be?
You give death certificate, we submit death certificate.
No, according to Indian law, we still say it should have crossed 28 weeks and it should be 1 gram, 1 kg.
1,000 gram.
And then it becomes a live birth. Were you asking that question? Whether you should give a death certificate? Are you saying that?
Yeah.
Sir, it is 1,000 gram and 28 weeks.
And 28 weeks.
For writing DC.
We don't. But now
DC, yes.
Sometimes what happens is we have come across patients who delivered a baby which is 26 weeks and still alive. So we're also in the doubt of whether to write it as because babies will be alive for more than a week. Sometimes they with NICU care they survive. So by law, so where do we have to put as a live birth?
Yeah.
Because 26 weeks and then the baby 700, 800 grams is still surviving.
Ma'am, if the baby is alive, irrespective of the age of gestation, then we have to write the live baby of weight so and so and gestation is so and so. But if it is that and 28 weeks and beyond, the period of viability what we consider, then we are calling it stillbirth.
Yes, ma'am, but when we write the parturition, that should be written immediately. So when we do not know how long the baby is going to survive.
Yes,
so when we write it and the baby is alive for a few years, we have to record it as a live birth only. So it is a live birth only.
Yes.
Dr. Chitra, what about what the feticide for these, which are definitely not going to be compatible? That's why we are terminating. I think that also should be considered. Otherwise, why should we terminate if the baby is going to survive? So yes, that is also not clear in the law.
It's not there in the law, but to have a baby Because if it's
Yeah.
born alive, and then what are we going to do with the baby? They will dump it and say, you look up the baby.
That is
So
true. That is
because
true.
it's better that we, do that also. You have to explain to the very,
But all
unless you
that
have a
should
person
come
who's,
in the all that should come in the law. Otherwise, tomorrow we do and we'll get into trouble. So all those things are not clear. All of us are
yes, ma'am.
still-
There are certain
yeah.
things, it does have some disadvantages.
Madam, we need to have a, if I may ask a question. So what we understand is that 24, 28 weeks we classify as abortion. So when we send a data for abortion and stillbirth, so clear-cut abortus, so that will go in under category of abortions. What about 24 to 28 weeks? Will they go as abortion or they will go as a preterm birth?
And
Whether
that's what,
it was
in
stillbirth
our
or
country, we have to take till 28 weeks. That is what we were discussing so far. 28 weeks,
Yeah.
if it crosses, then you say live birth. Before that, it should come an abortion. If it's born dead, if it's not alive, you put it as abortion. If it's live, it continues to be alive, then you put it as a record as a live birth.
right. Fine. So if it's a stillbirth, we put it as an abortion. Otherwise, 24, 28 live birth, it goes as a preterm birth.
Yeah.
Right.
Because now many NICUs, babies survive even if they're 600 grams. We had one baby which was only 600 grams, will survive.
That's true. We have 26 weeks surviving actually. So should we move to the second module?
Yeah, I request Dr. Shaili to start about safe abortion.
Thank you, Dr. Archana. Thank you, Dr. Chitra, for such a wonderful deliberation on the amendments.
Thank
Which
you.
were very clear from the slides. Now coming to the technical part. What are the updates in technology? So in this session, we will learn what are the guidelines, how we do the pre-abortion assessment, then actual methods of medical abortion and surgical abortion. So this is the WHO global guidelines for safe abortion, and Indian government has incorporated many of these guidelines in the national guidelines. And as Dr. Chitra has beautifully explained, the law was changed on 25th March 2021, but the rules was changed on 24th September. So with 24th September, this came into force, we can practically do the abortion up to the 24 weeks. So in all the guidelines, the three key areas are there in the management. One is the pre-abortion care, then the methods for abortion, and most important is after care and follow-up, in which we do the counseling for the contraception, which was very importantly raised by some doctor in the previous session. The need for contraception is very much in India, so we should take each and every opportunity to counsel the patient for proper use of contraceptions so that we can reduce the burden of abortions. Then there's the medical history, then physical examination, then if necessary, some lab investigations, and then discuss the contraceptive options at each and every time whenever we get the opportunity. If the woman chooses to have an abortion, she should be allowed to choose from all the methods which are available to her based on the duration of a pregnancy and her medical condition. So coming to the pre-abortion assessment and counseling, we have to take the detailed history regarding the LMP, her menstrual cycle. Then we have to do the general physical examination and pelvic examination to ascertain the gestational age, some laboratory examinations, and decision-making information, the abortion procedure and counseling. First and foremost is how we determine the gestational age. We all are gynecologists, we all know. Just to briefly summarize, by bimanual pelvic examination and abdominal examination, we can ascertain the gestational age. But there are some key consideration points in which, like in fibroids, in multiple gestation, in marked uterine retroversion, or obesity, or molar pregnancy, in which the gestational age may or may not be correspond to the gestational age. According to guidelines, routine lab tests are not a prerequisite for abortion services, but these tests may be performed as per the individual risk factors on the finding of physical examination. First, if the pregnancy is unconfirmed, you can do the pregnancy test. If you're suspecting anemia, do the hemoglobin or hematocrit. RH typing is done where there the availability of RH immunoglobulins are present. HIV testing and counseling, STI screening, and other lab tests as suggested by the medical history like kidney function test, liver function test, thyroid function test, etc. But all these are not necessary. If the patient is refusing the test, you cannot refuse the abortion. Ultrasound is not necessary unless you are suspecting that it is a ectopic pregnancy or missed abortion, only then ultrasound is necessary. In the counseling, we have to ask why she wants to terminate this pregnancy and what are the reasons for that termination. Then we have to tell her that abortions are safe in early gestation period. As the period of gestation increases, the abortion becomes risky. Importance of a trained provider performing the procedure for the safely. Available methods which are available to her, it can be surgical, it can be medical. Then we have to tell her the risk and warning signs with each and every abortion method. And then this is the most important thing where we have to counsel her that if she is not using any contraception, she can get pregnant. She can get pregnant as soon as the 14 days after abortion, because ovulation recurs only after 10 to 14 days after this abortion. But we should give advice regarding her normal activities, when she can resume the normal activities and sexual intercourse, etc., and follow-up care. We have to document informed written consent in the Form C, and we have to also write what is her decision to accept the post-abortion contraceptive or not. Important thing is, even if she is not willing for the contraception, she has to be provided with the abortion services. We cannot refuse on the basis that she is not opting for any contraception, but it is a counseling which we should done effectively so that she can choose any method which is more suitable for her. Then according to gestational age, if it is less than 12 weeks, we can use combination of mifepristone and misoprostol, or we can use the misoprostol only, or we can do the surgical evacuation with the vacuum. If it is more than 12 weeks, then we can use either mifepristone plus misoprostol only, and the dilatation and evacuation. But the dilatation sharp curettage is not recommended at any gestation period. So in first trimester, we have both the methods. It can be medical, it can be surgical. In the medical, we use mifepristone, which is the antiprogestin. It inhibits the action of progesterone. So it interferes with the continuation of pregnancy. Then after the mifepristone, we give misoprostol, that is the prostaglandin even analog. It causes the cervical softening, initiate the uterine contraction, and finally expel the products of consumption. So what are the dose? On day 1, we give mifepristone, the dose of 200 milligram orally. And if she is RH negative, we can administer the anti-D 50 microgram intramuscularly. Then we call the patient on day 3 after 48 hours for the misoprostol administration. If she is up to 7 weeks only 400 microgram is given. That is 2 tablets of 200 microgram each. We can give sublingual, buccal, vaginal, or oral. Any route can be used. But if she is in 7 to 9 weeks duration, then we have to give 800 microgram, that is 4 tablets. In addition, but this time we have to give only sublingual, buccal, or vaginal. Oral is not recommended at this gestational age. We have to give analgesic if she is having pain. Antiemetic can be prescribed, and again we can offer her contraception. We can counsel her for that. Then there is a schedule for the follow-up visit at day 15, just to confirm that all the products has been expelled. And if she has not opted for any contraception, we can again counsel her to use a effective contraception at this time also. So the oral routes, if the pills are swallowed, it is recommended only up to 7 weeks, that is 49 days from the LMP. Side effects are diarrhea, nausea, fever, and chills. In buccal, we place the pills between the gums and cheek, and we ask her to keep it there, and she can swallow it after the 30 minutes only after. But with this route, there are more chances of fever and chills if we compare it with the vaginal route. Likewise, sublingual, she has to place the pills under the tongue, and she has to keep there for 30 minutes. Again, there are more chances of fever, chills, diarrhea, vomiting as compared to vaginal routes, but this is the fastest action and highest plasma concentration with the sublingual route. In vaginal route, we can place the pill in the vaginal fornices, and woman is instructed to lie down for at least 30 minutes. In this route, we have the lowest side effects like diarrhea, fever, chills are lowest with this route. So this is the diagrammatic representation how we place the buccal tablets, two on the east side between the gums and the cheeks, the sublingual. We have to counsel the patient that bleeding can occur up to 2 weeks after the medical abortion, which is normal. But if she is experiencing heavy bleeding, or she is experiencing some dizziness, or she is having some shock-like symptoms, she has to report immediately to us. In rare cases, bleeding can last up to 45 days, but this is very rare. So we can counsel if she is having this problem, she has to come back to us. So who can provide the MMA services? This service should be available at the primary care level, but this primary care level should be have the linkage to a referral system, where if in case of any complication, case can be dealt with. In addition to all these centers should have the counseling and testing facility for the STIs, including HIV. They also have the abuse support services, psychological and social services, and other specialist health and medical services. In addition to this, if this patient is anemic, they should provide the iron tablets and necessary pain medications and emotional support if needed in the condition. Follow-up care. Routine follow-up care is not necessary according to guidelines if it is an uncomplicated medical abortion and we are using the mifepristone plus misoprostol. But if you are using only the misoprostol alone, then a routine follow-up is advised to assess the success of the abortion. If you are scheduling a follow-up visit, it should be after the 7 to 14 days after the procedure. And this time we have to do the contraceptive counseling, emotional support, and if she is having any medical concern, we have to address that. In follow-up care, we have to assess the woman's recovery and is there any sign and symptoms of ongoing pregnancy. We have to review the available medical records and referral documents. We have to ask about if she is having any symptoms since the procedure like pain or persistent bleeding. Then if she is having any complaint, we should perform a physical examination. And again, we have to assess the woman's fertility goals, like she wants an interval contraception or she wants a permanent method, then we have to advise her accordingly. So in summary, on the first visit, when the patient comes to us, we have to do a physical and pelvic examination just to confirm the gestational age and to see the patient. We have to confirm the eligibility. We can do it up to the 9 weeks. For 7 weeks and 9 weeks. We have to give tablet mifepristone 200 milligram orally, and if she is Rh negative, we can offer her anti-D if available. We have to tell the woman she has to return to us after 2 days, after 48 hours for the misoprostol administration. And then we have to give her contact address and phone number of the facility or center where she can go in case of any emergency like heavy bleeding, pain, or other shock-like symptoms. We have to record her experience of any side effect on the MMA card. Sometimes 3% of women may expel completely with the mifepristone alone, but we should ensure that these patients should get her misoprostol dose schedule as the advised. So we have to ask her to come on the day 3 and we have to give misoprostol. When she comes on the second visit, that is day 3, we have to give misoprostol. Up to 9 weeks, we can give either oral, sublingual, buccal, or vaginal. We have to observe her for the 4 hours. If she is experiencing pain, we can give her oral analgesics. And again, if she chooses for contraceptive method, we can give her condoms. We can start the OCPs. We can give her DIMPA. All these methods can be given on day 3. We have to tell the woman that mean period of bleeding is around 8 to 13 days. She can experience nausea, vomiting, diarrhea, headache, fever, and dizziness. But if she is having excessive bleeding, excessive pain and fever, she has to report back to the facility. And again, we have to tell her if there's no bleeding, even after 24 hours of the misoprostol, then she has to come for the additional dose. Majority of women abort within 4 to 6 hours after the misoprostol administration. When she come on the day 15, that is her follow-up visit, we have to do the pelvic examination to ensure that the process has been complete, os is closed, there is no signs of any infection. And then we can give her options. She can use the hormonal method, OCPs can be started, condom anytime she can use. We can insert the IUCD also if we are sure there is no infection, the completion of abortion process is there, we can insert the IUCD. And if she wants a permanent method, she has to wait for her next menstrual cycle, and that after that we can do the sterilization. We have to tell the woman that she can become pregnant even after 10 to 14 days of this abortion. So she has to use an effective contraception this time. She has to report back if there are no period within 6 weeks of the completion of the abortion process. Maybe she can get another pregnancy or the process has been not completed. She has to report back to us. USG is only done in which we are not sure on pelvic examination whether the process is complete or not. Of course, side effects, if she is having pain, we have to be respectful. It should be a non-judgmental communication. We can give her verbal support, adequate counseling. If they are not effective, then we can give her analgesic. But if she is having persistent pain, which is not responding to drugs, we have to evaluate it other, like it can be a case of ectopic pregnancy, it can be infection, it can be incomplete abortion. So we have to listen to the patient carefully. Nausea and vomiting, they are usually self-limiting, we can reassure, but if it is severe, we can prescribe the antiemetics. Diarrhea, it is again self-limiting, we have to reassure. If she is not responding, then we can give her medicine. And if she is having infection, we have to start the antibiotics. But what we have to do if there is failure of the MMA or there is incomplete abortion? We can offer her surgical method or we can repeat the MMA again. But practically we offer her vacuum aspiration. We do not repeat the MMA. If it is incomplete, she is having persistent bleeding or some products are inside there, we have to observe her unless the bleeding is heavy. If the bleeding is resolved, uterus is normal size, abortion is completed, we do not have to do anything, we just wait and watch. If it is incomplete, we can repeat the misoprostol. If there is heavy bleeding which is continuing despite the medicine, then we have to offer her surgical evacuation. If the patient comes with excessive bleeding per vaginum post MMA, what we have to do? If she is having bleeding which is more than her normal menstrual cycle, she is soaking 2 pads or more in 1 hour or 2. We have to counsel the patient, we have to wait and watch. If bleeding decreases over the time, then we can keep a watch on vitals and she can be discharged. But if the bleeding does not decrease over the time, it is persistent heavy bleeding, we have to watch the vital signs, we have to do the PV examination to rule out if there is any POCs in the cervical canal, we can do the distal evacuation. If the woman is stable and bleeding reduces, we can watch her and then we can discharge her. But if the bleeding continues, we have to do the ultrasound. If there are minimal decidual bits, they can be expelled on her own. We have to wait and watch. If there are more than minimum products of conception, woman is not stable, we have to give the vacuum aspiration. If the woman is stable, we can again give additional dose of misoprostol, either orally or sublingually. If despite all these things, pregnancy is continuing, then we can offer her surgical evacuation. After the MMA, surgical evacuation is important because we cannot ask her to continue the pregnancy as there are chances of some congenital malformation due to this misoprostol. Recording and reporting is very important even after the medical abortion because this comes under the purview of MTP Act and documentation similar as we do in the surgical procedures. So we have to fill the form 3, that is the consent form. We have to fill the form 1, that is the RMP opinion. We have to fill Form 2, that is the monthly reporting form, which we send to the district authorities, CMO. And Form 3, that is the admission register for the case record, which is kept at your center. After the medical abortion, second is the surgical. It can be a manual or it can be electrical vacuum aspiration. In first trimester, we can go for the vacuum aspiration up to 12 weeks. According to WHO, manual vacuum aspiration is the safest method, and the procedure should not be routinely completed by the sharp curettage. As we all know, the pregnant uterus is very soft and perforation can occur if we do the sharp curettage. So many of you are familiar with this MVA kit. This is the manual vacuum aspiration kit, which does not need electricity. This is the manually we create the suction and we can do the evacuation up to 12 weeks. It is a handheld aspirator to generate the vacuum, and it can be attached with the cannula. The cannula comes in different sizes between 4 millimeter to 12 millimeter in diameter, and we use according to the gestational age. And these cannula can be used in multiple settings. We can sterilize the cannulas and then we can again use it. Electric vacuum aspiration, which needs an electrical suction machine, we attach it with the cannula and then we can do the evacuation. Prior to evacuation, cervical priming we can do. It may be considered for the woman with a pregnancy of any gestational age to prepare the cervix. So it is soft and it is easy to dilate. We will not injure the cervix. The method which are available for the cervical priming in first trimester, either we can give the oral mifepristone, that is 200 milligram. It has to be given 24 to 48 hours prior to the procedure. Or we can give the misoprostol 400 microgram sublingually 2 to 3 hours prior to the procedure. Or we can insert it vaginally 3 hours prior to the procedure. And sometimes if you are comfortable with, you can use the laminaria, intracervical laminaria trends also. 6 to 24 hours prior to the procedure. Commonly we use the misoprostol in our settings. For the pain management, it is very important component of the quality abortion care. It reduces the pain and anxiety and makes the woman comfortable. There are two components of pain management. One is the non-pharmacological, in which you give the verbal support, and another is pharmacological, in which we use the medications. So for non-pharmacological pain management, it is a psychological support. In each and every step, you explain the patient. Like, we are putting the speculum, we are holding the cervix, you will feel it, we are giving the injection for the cervical paracervical block. If you explain it, she can be very understanding and she can cooperate. And we have to perform the procedure gently and smoothly and encourage the woman to relax, breathe deeply during the procedure also. But if the patient is very anxious, then we can give anxiolytic like diazepam, or sometimes patient is very anxious, we have to give the general anesthesia. We can use diazepam for this. Cervical dilatation we have discussed. If she is having uterine cramping, we can give the analgesics. This is the pictorial representation. We prepare the instrument by creating the vacuum, close the valves according to the manual, and we ensure the patient is fully prepared. She has evacuated the bladder. She has been given pain medication if required. Then we perform we prepare the cervix by antiseptic preparation. Then we administer the paracervical block. Then dilate the cervix if needed. Then we insert the cannula of appropriate size. We go up to the fundus and then we withdraw 1 to 2 centimeters away from the fundus, remain inside the uterine cavity, and then we rotate the cannula at 10 to 2 o'clock position with a smooth, gentle motion, and then we release the vacuum so that the products are sucked into the tube, and then we empty the tube into the bowl. The signs that uterus is empty, you will get the red or pink foam without any tissue passing through the cannula. There will be gritty sensation over all surfaces of the uterus, and the cervix will start gripping your cannula. Uterus contracted around the cannula, and the patient will feel the uterine cramping. After this, you have to inspect the tissue that you have the coronary villi inside this, and then you can proceed with the contraception in the same setting. If she is opting for the IUCD insertion, you can do the IUCD insertion. If she has opted for the sterilization, it can be given it can be done in the same setting. And after that, you have to process the instrument. You have to disinfect it in the 0.5% bleach solution in 10 minutes, and then send the instruments for the autoclaving. After the procedure, monitor her for any complication and provide management if needed. Once she is stable, she can leave the facility and she is having some attendant with her. Ensure that woman has all the necessary information and medication prior to leaving the facility. And you have to document all the outcome of the treatment, including if there is any adverse event during the procedure, in her case record. If she is the complication is there, like incomplete abortion, if there's infection, they're bleeding, the ongoing pregnancy, all has to be dealt accordingly. And each and every step you have to consult the patient for the contraception so that she can choose and you can give her the best method. In the same setting, you can assess for any sexual or reproductive health need that may require additional care. According to new recommendation, no follow-up is required until you have used the meso-alone regime. So to summarize, we have made a historic progress in improving the access to safe abortions. Technologically, there is no much changes in the update in last decades. We are using this since 2 decades. As providers, it is up to us to ensure the safety and quality, especially in the context of amendment law. Along with safety, we also need to focus on the respectful abortion care. We should be very non-judgmental. We should be empathetic towards our patients. And every client, public or private, this abortion care, this timing is an opportunity to inform, to educate, and equip our patients with proper information on the contraception and counseling. And after this session, you will have a post-test. You have to fill that post-test and give the feedback. Only when you submit this post-test, you will get your certificate. If you do not fill this post-test, we will not be able to send you the certificates. So this was all about the technical updates. Any queries?
And I will request to be there because certain queries are there, and any of you can answer. We administer NTD on day 1. So is it okay? So I think that is no doubt about it. Same way we have to give NTD as we were giving as early as possible. Then
Yes.
the question is who is responsible? This is a very important question. Who is responsible for the live baby? If the patient says, I did abortion in first place and won't stay and pay for the live baby care in NIC or otherwise. So anybody can give suggestion before we...
So this is a very
If
legal
you have an
question.
answer in mind
So
and
this
yet
is
do
out
not
of
speak up
perspective of this,
to your mobile.
I think this session.
Yeah, and
Comment?
Pregnancy, we have to decide whether the termination of pregnancy itself means that it should not be born alive.
yes.
For the, of course, the government will not say that because it sounds to be
Yeah.
that,
Yeah.
even the feticide subject also.
Yeah.
As Professor Lata pointed out. So, like government cannot put on papers that you go ahead, come on, do feticide because it is used in India.
Yes.
So it is adjunct to the abortion process itself. So as it is not saying how you are going to do medical termination or how you are going to termination. So it is left to the clinician's judgment.
Yeah. I think that is correct, and that's why the importance of medical board has been given stressed upon between so that these things are discussed beforehand. Then comes one of the question: if divorce or widow after 20 weeks of pregnancy, then MTP allowed. So I think Dr. Chitra has already discussed about it.
Yes, this has been discussed.
Yeah,
I
that's
already
Comes in
told
special
you.
category.
Chitra has already discussed.
Yeah.
And then some question is how to know whether board is there in one state and how to approach it.
How to know? You have to meet your JD
Yeah,
in your
yes,
particular
yes.
place, because
Your CMO
the
can tell
joint
you
director,
this.
Yeah.
Your CMO,
every place will have the joint
CMOs can
director,
tell
so you
you.
have to apply to them.
Then
Joint director, family health,
yes,
health,
yes.
family.
In case
health and
nobody is
welfare.
there, you have to just ask the deputy collector or DMHO itself. They will guide you better in case you don't have anybody in and around your area, and they will be knowing the medical
You go
board.
to the nearest medical college.
Then comes the humanitarian grounds. Most people claim this. I already have 2 children, can take care of no one, no more, and because contraception is not
It
used.
has already been answered and
So I
discussed.
think, yeah, Dr. Chitra has already discussed. So should we move ahead with the third topic? And
There was one question about previous cesarean and MTP. What's the dose?
Yeah.
Is it the same dose or should we use a lesser dose, Dr. Shaili?
No, there's no provision of lesser dose. This is not mentioned. We use the same dose in previous LSCS also. But these patients should be ideally admitted in the facility itself. We can not send her to home. So we admit the patient in the hospital, and then we give them medical abortion under the observation, so that we can tackle any complication which is there. So these patients should not be allowed to go home after the misoprostol or mifepristone administration until the procedure is completed. As far as I know.
It all depends upon, in previous cesarean cases, you have to keep watch on the patient. It all depends on the patient, what the patient was, how is the scar, and how the history of the patient is.
Yes.
All these things can determine. This is just a question of your own discretion, what you have to do. So Dr. Shaili has completed her module very well. She has really explained everything very well.
Now I request Dr. Rekha to join us, and WHO Saver Toolkit, Safe Abortion Values, Evidence and Rights will be dealt with Dr. Rekha. And if any questions are there, please keep on putting in the chat so that we can discuss.
Okay, so thank you. So I will start now with the module 3.
Yes.
So the module 3 consists of safe abortion values, evidence, rights, and respect. The main thing is, what is respectful abortion care? This module aims to define respectful abortion care. Highlight. Any problem? Highlight. Who's speaking?
Shriman, can you stop all the...
Highlight how norms and stigma affect the services and provide WHO Saver resource for our respectful abortion care. The momentum has been created, law has changed, dissemination needs association and OBGY provider support. Since the law has changed, it needs the gynecologist support. FOGSI is the largest provider base for abortion care. Online training possible due to COVID. Respectful abortion care can reach all the providers. Medical method of abortion uptake has increased. Early, safe, ensure no PCP and DT conflation. Patient safety, respect, and quality matters more than ever, and we can have a role to play. What is respectful abortion care? Adopted from respectful maternity care, recommended by the World Health Organization, respectful abortion care refers to the care that maintains safety, dignity, confidentiality, and ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. What is respectful abortion care? In simpler terms, the respectful abortion care means you as a provider and or as a patient treat and are treated with dignity, empathy, and compassion regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history, pregnancies, miscarriages, and abortions. If you ever feel that something isn't right, speak up. As health professional, it is a duty to listen and support, and communication is the key. What are the norms and stigma? So in this chart, you can see the category of disrespect and abuse and what are the rights of every woman. Stigma and norms perpetuate disrespect and abuse. So the things highlighted in red are physical abuse, slapping, intimidating physically, verbal abuse, non-consented care, shouting and screaming, sexual abuse, abuse of power and taking advantage. Fourth is stigma and discrimination, which will be shown in the Saver videos. Failure to meet professional standards of care, poor rapport between women and providers, and health system conditions and constraints. So these 7 categories of disrespect and abuse, they go on from the physical abuse to failure to meet professional standards, poor rapport, and health system conditions and constraints. The right of every woman is freedom from harm and ill treatment, right to information, protection under laws, MTP and POCSO, informed consent and refusal, and respect for choices and preferences, dignity and quality of care. The right to timely health care and to highest attainable level of health, liberty, autonomy, self-determination, and freedom from coercion. So the abortion, whenever a person comes for abortion, there should be no physical abuse or verbal abuse or sexual abuse or taking advantage of the power of a person and then taking her, bringing her physically to get an abortion done. It should be her own discretion how and what to get done. And also the healthcare professionals should meet the standards of care and should establish a proper rapport, and the healthcare system should be proper so that highest attainable level of health and there is freedom from coercion. So these things should be taken care of. Now, what means domains of respectful abortion care? There are 12 domains of respectful abortion care. Everything is highlighted in green. It should be free from harm. It should be confidential. It should preserve the woman's dignity. It should respect the woman's choices. We should engage in soft skills. There should be an informed consent. There should be access to support. And the quality of the abortion should be good, and equitable abortion care should be provided. There should be availability of competent and motivated providers and provision of contraception advice and commodity security. This means that post-care of the abortion should be there, and there should be continuity of care and counseling even after the abortion. So the time to strengthen and implementation. One provider, more responsibility. So the one provider should counsel, should provide contraception services, referral, and compassionate care. Up to 20 weeks, as we know, it is one RMP, from 20 to 24 weeks, 2 RMP, and medical board beyond 24 weeks. So the important changes for the provider opinion: every patient is an opportunity for respect, and as providers, onus is on us to educate and also reduce the sex-selective abortion. Now from 20 to 24 weeks, in special cases, the need for sensitivity and judgment-free timely services. This expands the eligibility, especially the young people, survivors, unmarried. Everyone needs unbiased care, and we need to overcome our own biases. So up to 20 weeks of gestation, and special case from 20 to 24 weeks, that is rape and less than 18 years female. And after 24 weeks, there is no limit, and it is specially for birth defects. But there was a question in the chat box that can we provide for 20 to 24 weeks in a case of a widowed woman? So in that also, it comes under a special category only. So it can only the consent of 2 RMP is required. So the third is prioritized confidentiality and safety. Respect begets respect. As providers, we need to be mindful of socio-cultural aspects. Name and other particulars of the woman seeking abortion has to be confidential, except to a person authorized in law for the time the ground of failure of contraceptive extended to woman and her partner. Respect, quality, and dignity of all types of abortion. So, guide to avoiding stigmatizing language. WHO training for safe abortion values, evidence, and right. The Saver Toolkit. Self-spaced games. So now I think from 1970s unsafe abortion to 2000 safe abortion and now 2020s respectful abortion. There are a few recap questions. According to WHO Health Organization, restricting access reduces the number of unsafe abortion. Is it true or false? Can you answer? Is it true or false? Should I move on? So it is false. According to WHO Health Organization, restricting access reduces the number of unsafe abortions. It is false. Now the next question is, 30-year-old woman recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Will you ask her to continue the pregnancy?
No.
No, yes, it is no. Because it is respectful abortion, so you have to respect the choice of the person getting having an abortion. Now, I've finished with these slides. Shall I go on to the video next?
Sure. Yes, ma'am.
So I'll go to the Saver video. Which one should I? All the three should I show? All the three. So I'll start with norms and stigma. I'll start with norms and stigma. Can you see the video? Can you see the video?
No, we are not.
Social norms are the unwritten rules of behavior that are considered acceptable in a
You can't see.
We are able to see.
You can see.
group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So,
Shriman, can we have the next video?
yes, I'm sharing it. Can you see?
Yes, ma'am.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 Ps provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified. How to talk about abortion, a guide to right based messaging. Abort a child is medically inaccurate.
Sorry, it is the same one.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Seva is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
all the videos we have seen, and now I think, do we have to discuss anything? Anybody?
I think there
Where
is
is
no.
Dr. Archana? Dr.
Yeah,
Archana.
thank you. I think no chats are there at present. So, Dr. Rekha, be there in case in the end they are asking any questions. So, we can
Go
discuss
ahead.
with them.
Yes. Go ahead.
Yes, yes, ma'am.
Dr. Archana, you can start.
I am going to start it. Just 1 minute. I'm just. We are going to discuss about pre and post abortion counseling and the importance of contraception. So,
Madam, you didn't share your PPT, ma'am.
yeah. Is it see? Now can you see?
Yes, ma'am, but make it full screen.
Yeah. Is it okay? Is it okay? Yeah.
Okay.
It's not full screen, madam.
So what is counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feeling, and perceptions. So we already know what counseling means. Discuss with the patient in a comfortable atmosphere so she can not only discuss her fear but apprehensions and doubts about the services as well as the outcome. So integral part of comprehensive abortion services as important as the procedure itself, and women may need help in decision making wherever needed. The spouse should also be counseled. Not be that only women has to be counseled, the spouse also,
Madam, sorry to
there will
interrupt
be
you,
discussion.
madam. Your slides are not moving, madam. It's not
Yeah.
full screen also.
Yeah, can you do from your side then?
That's what I'll do. Just give a minute.
Yeah. Can we start?
You stop sharing the screen, then I'll share the screen, ma'am.
Yeah. So now we are going with pre and post abortion counseling. And counseling we have discussed is a structured prescription. Shriman, third slide, please. The third slide. Shriman, can you move? Can you go ahead with the third slide?
Yes, ma'am. Now in third slide only. Counseling.
Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feeling, and perceptions. So, counseling is an important part of abortion. Next slide, please. Shriman, next slide. Wherever needed, the spouse should also be counseled. It is not important that we have to counsel only mother or the woman, but we have to insist on counseling the spouse also, because any queries has to be discussed in so that both make a shared decision. Next slide. So pre-procedure counseling, the critical role is to help women decide about termination of pregnancy, to help women to choose the method of termination, to ensure delivery of complete information about the procedure, and to help women to adopt a contraceptive method. So it starts with decision, then choosing, and then discussion about it, and ensuring the privacy and confidentiality, and being non-judgmental and be sensitive, and use simple language. It should not be that we have to use only scientific words which can cause a problem and patient may not be able to understand what we are speaking about. And if she has made up her mind for termination of pregnancy, assess her for the procedure. It should not be that we have to be judgmental about it. We have to understand what decision she has made, and we have to be respectful for it and help her. And we have to, what important is that because quick return of fertility can be there, and this is the opportune time for contraceptive acceptance. Minimum 6 months gap before next pregnancy should be there, and the health benefits and better future pregnancy outcome will be there if the patient has been given the proper counseling. 90% of abortion related maternal mortality can be prevented by ensuring contraception. Next slide. Then what is pre-abortion family planning counseling and when to start? It has to be started when the patient comes to us at the first visit itself, and grief management delay and should not be the exception when she is very shocked, say, because if the congenital anomalies has been diagnosed and she is in too much of stress, then we have to give her time. Otherwise, the first visit itself, it should start. And importance, we have to tell about the return of fertility, help with the choices which are available, and the method specific counseling should be given. If we are using surgical method, what all complications can happen, how much rest she has to take, or the medical method, what all precautions she has to take, and the high risk behavior also should be discussed. If the woman is not willing for any contraceptive methods, then also we should not refuse medical termination of pregnancy. So this is very important point, that if the woman says that I don't want you to use any contraceptive methods, I'm not mentally prepared for it, for that stand only we should not refuse the woman medical termination of pregnancy. Next slide. The assessing suitability for post-abortion contraception. So abortion process should be complete and no existing infection should be there. No injury to genital organs should be there, and chances of fresh pregnancy should be ruled out. So we should always see that it is as safe to the mother as possible. In spite of all precaution, if you have any doubt, we have to discuss with your senior or the colleague and see that there is no complication, no existing infection for the patient. Next slide. Shriman, the post-procedure counseling has a critical load. It reinforces the need for continuing the use of contraceptive method chosen and ensures the woman has understood the precaution. It is not only that she has understood, she has to take care during post-abortion period, and it should be counseled for contraception in case not previously accepted. Many times patient may not in the beginning accept all the precautions, all the method, but when she is going through, then she will be understanding the importance of contraception, and then she may be willing to take the precautions as discussed earlier. So we have to give her importance in the post-procedure counseling also. Next slide. Shriman, can you put next slide? The post-procedure counseling, we have not to reassure her in any case of any problem, but we have to repeat the information so that she is having understanding about the care and the danger sign. Say if she is having high fever, she goes home and she is having high fever, so immediately she has to come back. If she is having persistent bleeding, she has to come back and inform. So these things has to be discussed with the patient so that the patient is comfortable with the counseling itself. Next slide, please. Shriman, can you put next slide? Yeah. So post-abortion FP counseling is appreciate immediate care. What we can give is intrauterine contraceptive device, medroxyprogesterone acetate, follow-up protocol, and the continuity and the cards. Undecided, there may be patients who are undecided. So in these cases, it will help them to allay the anxiety, the importance of immediate adoption and chosen, and the extended period should be there, and couple counseling can be done. And emergency contraceptive pills also can be explained to the patient. So it is not only that we have to post-abortion counseling will be helping in future, but also for immediate care also, and it will importantly allay the anxiety of the patient to use any method of contraception. Next slide. So the post-abortion contraceptive methods, when to start, and any specific information we have to give. When it comes to barrier methods or condoms, as soon as the sexual activity is resumed, they are supposed to be started. Either it is first trimester or the second trimester. No hormonal side effects can be used without consulting a health provider. It is easily available prevention against sexually transmitted infection and enables men to take responsibility of contraception. Hence, it is equally important in the post-abortion counseling also if the spouse is made the part of the counseling session. Next slide. Can we go ahead with the next slide? Then comes the beside barrier method, we are having intrauterine contraceptive device. Intrauterine contraceptive device should be inserted immediately or up to 12 days after confirmation of a completed abortion using the surgical method. With medical abortion inserted around day 15 of the process provides complete, so that we are sure that no retained product of conception is there, and then we are putting intrauterine contraceptive device. And when it is a second trimester, abortion can be immediately kept or up to 12 days after the procedure is complete and contradictions are ruled out. The advantage that it is highly effective, can be kept up to 5 or 10 years, and can be provided by trained doctors, MBBS and above. No interference with sex and immediate return to fertility on removal. No hormonal side effect. Next slide, please. The advantage of intrauterine contraceptive device is that the patient should be reassured again and again that it doesn't interfere with the sex, what the patient many times fears, and it can be kept for a long time. So every day she need not come for follow-up. Maybe after 1 month, immediately after post-abortion, when she is coming for follow-up, we can recheck the intrauterine contraceptive device also. Then coming to hormonal contraception. When to start? When the abortion is after first trimester, immediately or up to 7 days after abortion, using the surgical method, we can start it. It can be started on day 3 with a dose of misoprostol or within day 15 of the process. Second trimester, immediately or up to 7 days. Why we are always having the 15 days gap there? Because of any retained product of conception is there, we can rule out, and then only we can start the either intrauterine contraceptive device or combined oral pill. Then what are the additional information we have to provide to the patient? That it is important that it will be regulating the menstrual cycle, can be provided by all health workers, and no interference with sex, and offers protection against ectopic pregnancy, endometrial and ovarian cancer, benign disease such as fibrocystic disease, but not suitable for women who are breastfeeding and babies less than 6 months old. Can you put for next slide, Shriman? The long-term injectables. And now, even in government hospital, the Antara is, and what it contains is medroxyprogesterone acetate. Immediately or up to 7 days, it can be started on day 3 with a dose of misoprostol. In second trimester, it can be given up to 7 days after the abortion. It is highly effective, and the privacy is maintained, can be given by A&M also. No interference with sex, offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroid. Next slide, please. The advantage of MPA is that even if the patient is lactating or feeding her baby, then also we can give medroxyprogesterone acetate, and it is quite safe. Then coming to permanent method. The female sterilization can be performed after an abortion in the absence of any infection or severe blood loss concurrently or up to 7 days. When we are giving medical method, then it can be only after the first menstrual cycle. The second trimester mini-lab sterilization can be done same time or up to 7 days after the abortion. In these cases, laparoscopic sterilization is not recommended because of the edematous tubes, and it is always better that we can wait, and in case we are planning mini laparoscopic sterilization. What are the additional information? It is the permanent method, so we have to counsel her about the importance and non-reversibility also. And but the advantage is it is effective, offers protection against ovarian cancer also, no long-term side effect, no effect on breastfeeding, and it doesn't interfere with sex. Now coming to male sterilization or vasectomy performed on males independent of timing and procedure of the abortion. So if the patient has come with a spouse, it is always good that first counseling before the abortion, and after the abortion process is complete, we can reinstate to the patient and her husband the importance of vasectomy, and then the acceptance in the male partner is very good. And then the permanent, it is always permanent method, no interference with the sex. This has to be explained and insisted upon, and no long-term health risk to the patient will be there. And the couple must use any other method till the semen test is negative. We should not say that immediately after vasectomy it will be, she won't conceive, and these things should be explained to the patient and her spouse or husband. Next slide, please. Then when contraceptive methods with medical abortion, when we have to give, and there are certain restrictions with it, we have to follow it. Next slide, Shriman. Can you go ahead with the next slide? When can be given the vacuum aspiration? Can it be given in combined contraceptive pills? Yes. Injections? Yes. And tubal ligation also can be done. So why we are so specific about each procedure, that can it be done or not, what time it has to be done, so that as soon as the patient has come to us and she is about to leave us after abortion, this process is over, it is important that she doesn't have unplanned pregnancy repeatedly, and she should not think that this is the only method which can be used to prevent unplanned pregnancy. So we should always insist on the contraceptive part whenever we are doing an abortion. But at the same time, we should not refuse a patient if she doesn't want to use any contraceptive methods. So what are the sexual and reproductive health services, and what changes has happened after the COVID era has come with the insistence of telecommunication and teleconsultation? We have improved that it can be used for the patients also. Shriman, next slide. Can we go ahead? Yeah. So how the services can be used? It can be used for teleconsultation and the telecounseling, and she can have guidance also. Many times, particularly when medical abortion is being given to the patient, then she may have certain doubts when she reaches home. So then also we can have teleconsultation and guidance regarding it, and she can be given some links also, so that she can understand the procedure and she feels more empowered with the awareness and education what we have given to the patient. At the same time, she can be guided what precautions she has to take later, so that immediate no complication occurs for her, and it is for the safety of the patient. Coming to the next slide. Shriman, can you go ahead with the next slide? So what are the technical website? It is Hamdo. Then social media, Ask Tanu, YouTube, infographics, helpline, patient education platforms are there. So which can be helped with the education for the patient and her spouse, and they will be feeling more empowered after attending these YouTube session, and they can understand it. There are helpline also which can help her to decide and discuss about the basket of choices she is having, either with the method of abortion as well as the contraceptive methods which she can use later. Can we come to the next slide? Shriman, there are certain questions which has been asked. One is contraception in children less than 18 years unmarried. So in these, before going ahead with these slides, I will just say that first we have to discuss about the importance of the age factor and high risk behavior. So these patients are at high risk. So we have to tell that the POSCO Act is there, and they have to be the parents have to be informed about it. So we should not just go with the contraception in the age less than 18 years until the proper counseling of the patient and her parents has been discussed. If she is against any contraception or she insists also, then also the counseling has to be done with keeping privacy for the patient and her parents or the guardian, whosoever is there with the patient. Then coming to assessment, the applicability of the components of CAC, the assessment confirm the diagnosis, contraceptive needs, counseling, video conference, Zoom can be there, and the follow-up can be there. The advantage of the present technology is not only we can have hybrids, the total physical one, we can have the hybrid services in which one visit is physical visit, and then they can be 3 visits again, and then the followed by what we say is online consultation, so that the patient is never be away from the consultation and care which has to be given to the patient. Realize the need. Next slide. Srimad, can we go ahead with the next slide? So realize the need and bring the couple on board and strive for 100% coverage. Capitalize on the basket and availability and technology as far as possible. What are the concerns, the policy, the malpractice, the service cost, and the access? Adolescent reproductive health needs both online and offline help. And importantly, we should not leave the patient as soon as the abortion is over. The counseling part has to go for a longer period whenever we are dealing with adolescent, because they may need proper care, and many times they may not come to us until they are feeling empowered and confident in the health services. So at any point, we should not be judgmental about the patient, and we have to take time, see that privacy is ensured, and enough time is given to the patient, particularly when the patient comes for any abortion and in adolescent age group. So there are certain questions of IUCD immediately after MTP. Yes, we can put, as particularly when we are doing surgical evacuation. In those cases, we can immediately put intrauterine contraceptive device if we are sure that there is no retained product of conception, so that at the same time we can do it, provided the patient has been counseled before we have taken her for the method itself. So when we are doing MTP beforehand itself, if we are having the consent, then only we are supposed to put. It is not that while we are doing, then we are informing the patient and putting the contraceptive device. Then one more question is there: for minor, consent should be given by whom? Minor comes under the POSCO Act, so all those regulations has to be followed, and it should not be taken as only the consent of mother has to be taken. We have to see that it is properly informed and all the legalities are being followed in these cases whenever we are dealing with minor. Dr. Chitra, anything else you want to contribute in these questions? One is posed regarding investigation. Somebody has.
Cesarean section, like I said, but WHS is from you can second trimester from the 14th week till the 28th week. You can use 400 micrograms every 4th hourly, but you should be careful when you're dealing with the previous cesarean, because sometimes you could have a scar rupture, like already has been said. You should monitor them in the hospital. And don't give it very frequently, give it only once in 4 hours.
Yeah.
And POXO is a separate topic by itself, so it really can't be combined with this MTP.
That's what I feel, because it is a separate big topic, and we have to only know that all the formalities, what has to be done, has to be done. It is not that just we quietly do anything. It has to be informed Not only the patient, but it should be treated as medical legal case, and it has to be informed even in private setup. It should not be assumed that we need not inform and do off the procedure, because all standards have to be maintained, and the registration, everything, the consent form, everything has to be kept for a minimum period, so that anytime the question asked, we are ready with the evidence, all those things. And someone of the person has asked about the lab investigation. So lab investigations, I think, are the same as we were doing earlier. There is no change in the investigation part. We are supposed to do complete blood picture. We have to see the viral markers, blood sugar, thyroid.
But these investigations are not really mandatory.
Yeah, it is
You
not
can
mandatory.
do it for to
Yes.
safeguard yourself. Supposing you know that the person is would definitely like to know whether she's RS positive or negative. So it's important that you do it. But it's not mandatory. Suppose it's a PHC and then she comes and all these things are not available, you could still go ahead with without all those investigations. The second slide said it very clearly. It's not mandatory. Even an ultrasound is not mandatory. Only if you have a doubt of having an ectopic or a missed abortion.
In those cases only we have to do. I think the indications have already been discussed by Dr. Chitra, so we won't be going for again discussion about the indications of termination of pregnancy. In the first talk itself, it was discussed.
After the 24th week of pregnancy, the only condition is the congenital anomaly.
Yeah.
Because after that, all the other things will not come into play, because they are supposed to do that only till 24 weeks. But after 24 weeks, it's only on congenital anomalies you could extend the time of termination, not for any other reason.
So please, I will request all of the audience that you have to fill the form. Until you are filling the form, it won't be given the certificate, and it becomes very difficult, because it is needed for you, and whichever society has not yet completed, they have to organize, and so that everybody, all the members are aware of the changes what has been made in the MTP Act. That has been the aim for whole RAC, and I request all of you, whosoever are the secretaries or president of the society, so that you can conduct in your own society also, and everybody gets involved in this training session. So can we call a day?
Yeah. Can we leave, Archana?
Thank you, ma'am.
Thank you so much.
Thank you, ma'am. Dr. Rekha, thank you so much.
Thank you.
Thank you, ma'am.
Madam, I shared the posters and the feedback link in the chat box, madam.
Can you send it by mail? It will be easier for us.
Please see, all of you, please fill the form so that it becomes easier for you. Thank you, Dr. Shaili.
Thank you, everybody.
Thank you. Thank you, Shriman, for all the help.
So can we leave now?
Yeah. Thank you. Thank you.
Welcome, madam.
To everybody, because they're asking still that how to get the form.